I'm so grateful to have been invited here to give this talk. This is a very exciting and rapidly evolving subject. I have nothing to disclose. So the goals of my presentation are to discuss an approach to genetic testing in neuromuscular disease. I will review typical presentations of the most common and the treatable adult genetic neuromuscular diseases, and I also want to review some new management and treatment options. So there are some challenges with genetic diagnosis in neuromuscular disease, one being just the huge number of genes that have been implicated, over 600, with over 100 genes implicated in hereditary neuropathies, 60 for muscular dystrophies, and over 30 for motor neuron disease. Another challenge is genetic heterogeneity. So this is the term we use to describe that mutations in genes involved in varied cellular processes can result in a similar phenotype. I think a great example of this is with mutations in the dystrophin sarcoglycan complex or even the nuclear pore. Both can lead to limb-girdle muscular dystrophy. Another challenge is phenotypic pleiotropy. That's where one gene can cause multiple phenotypes. An example of this is dysferlin, which can cause a distal or a limb-girdle muscular dystrophy. Another great example is the ataxin-2 gene, where repeat expansion can cause either spinocerebellar ataxia or even ALS. And there are reasons we would like to get to the diagnosis sooner if we can. An early diagnosis can reduce emotional distress. It can reduce financial burden of repeated referrals to medical specialists and repeated diagnostic testing, and can also reduce exposure to unnecessary treatments and procedures. But most excitingly, we now have treatments available for some particular genetic diseases, with more in the pipeline. We actually have a list now of genetic neuromuscular diseases with FDA-approved drugs. So here it is. At the top of my list is Duchenne muscular dystrophy, which I won't be talking about today, but there are now 4 FDA-approved medications to treat Duchenne muscular dystrophy, and it's estimated that up to 29% of individuals with Duchenne muscular dystrophy will have a mutation that's amenable to one of these drugs. Next up is spinal muscular atrophy, which I also won't be talking about today, but these drugs have totally revolutionized the course of this disease. I will spend some time talking about hereditary transthyretin amyloidosis and Pompe disease, but I think it's just a good idea to keep this list in your head and perhaps have a lower threshold for testing for these. So there are some clues that you might be dealing with a genetic neuromuscular disease, especially long-standing symptoms that are slowly progressive, exam findings out of proportion to symptoms. My favorite example of this is in McArdle disease, where an individual is actually at risk of muscle contractures and rhabdomyolysis just with a brisk walk, and yet they often refer to themselves as just being unathletic. There may or may not be a family history. Sometimes you'll see musculoskeletal changes like pes cavus, scoliosis, contractures. They may endorse a history of delayed motor milestones or a history that they were unable to keep up with their peers in sports. There's been such changes in genetic testing in the past 20 years. We went from the Human Genome Project, which took 200 scientists 13 years and $3 billion to complete, to today, where we have targeted next-generation sequencing panels that are widely available, fast, and even free. We also have whole exome sequencing and whole genome sequence available to us with ever-decreasing turnaround times. I really enjoy this figure. I think it's a great representation of how our diagnostic testing has changed over the years. So in the past, we would perform our clinical evaluation, order tests, do a muscle biopsy, and all of that would direct us to test for one specific gene. Today, we order genetic testing often before at the same time as other tests, and muscle biopsy is often used to confirm whether or not a variant of unknown significance is actually significant. So next generation sequencing panels have been so helpful, but it is important to remember that there are some genes that are not typically included on these panels. I think this is changing, and this might not be an issue in the future, but the next generation sequencing panels historically haven't been designed to test for deletions, duplications, and especially repeat expansions. And I just want to call attention that this list includes some of our most common genetic neuromuscular diseases, our most common hereditary neuropathy, CMT1A, and the most common inherited adult muscular dystrophy, myotonic dystrophy type 1. So this is just a proposed way to approach a patient with suspected genetic neuromuscular disease. I would first start with a history and physical and determine whether or not they had one of those diseases, a phenotype that fit with one of those diseases that's not included on typical next generation sequencing panels. If so, I would go, if they did have one of those diagnoses, or I presumed, I would go straight to targeted single gene testing. If that was negative, or if the phenotype didn't fit with one of these conditions, I would move to a next generation sequencing panel. If a variant was found, you could consider other testing, such as muscle biopsy, to determine whether or not that variant was significant. If the next generation sequencing panel was negative, you could then consider whole exome, whole genome, or in research settings, sometimes RNA sequencing, proteomics, or metabolomics. So I'm going to switch gears now and go through some cases that highlight some of the presentations of the common and treatable genetic neuromuscular diseases. Starting with this case of a 20-year-old woman who is coming in with frequent tripping and falls. Her father had similar symptoms and was diagnosed with a neuropathy in his 20s. On exam, she has sensory loss to all modalities, and a length-dependent pattern. She has weakness in her feet, high arches, and hammer toes. So she had an EMG nerve conduction study which showed a uniform demyelinating neuropathy. Because of this, we sent for PMP22 duplication, which was positive. So she was diagnosed with Charcot-Marie-Tooth 1A. So I'm just going to briefly review CMT. This is the most common inherited neuromuscular disease, and CMT just refers to this diverse group of hereditary sensory motor neuropathies. Sometimes they're referred to as hereditary motor sensory neuropathies. The prevalence is about 1 in 2,500. Like I mentioned before, mutations have been reported in over 100 genes. They can be dominant, recessive, or X-linked. 4 genes account for up to 90% of cases, with PMP duplications accounting for the majority, up to 60% of cases. So the typical presentation is usually in the second decade of life, a patient will present with slowly progressive muscle weakness and sensory loss. This is another case where the sensory loss you see on exam is much more significant than what they've reported. You'll also see atrophy in a length-dependent pattern. The image on the top right there shows this kind of distal tapering due to the muscle atrophy. You may see foot deformities such as pes cavus, pes planus, hammer toes, and they should have reduced reflexes. So the classification of CMT is evolving as well. So historically, for example, CMT1 referred to autosomal dominant and demyelinating cases, and then there would be a letter after the number that indicated the gene. However, we now have more genes than we have letters of the alphabet, so this might be changing in the future. So I have an algorithm here for how to approach suspected CMT. A good way to start is to look at the nerve conduction velocity in the upper extremity. If it's less than 38, I would go down the route of checking for PMP22 duplications or deletions first. If that's negative or the neuropathy is axonal, you could then proceed with the next generation sequencing panel. It is a good idea to pick a panel that contains more than just CMT genes. Sometimes distal myopathies can mimic motor neuropathies, or sometimes ataxias or HSP can actually present with a neuropathy, so it's a good idea to include these two. If that is negative, you could then move on to consider whole exome, whole genome, or mitochondrial DNA testing. So unfortunately, for now, the management of CMT is symptomatic. We do encourage PT-OT, exercise, NSAIDs, and neuropathic pain medications, surgery for foot deformities, failing conservative treatment, and the avoidance of neurotoxins. There is some exciting research in a mouse model of CMT1A where a small interfering RNA actually was able to reduce the PMP22 protein levels, and the mice had improvement in their disability. So hopefully down the road, we might have targeted treatments available for CMT as well. So the takeaways from this case, start with PMP22 when you're approaching presumed hereditary and demyelinating neuropathy. Next generation sequencing panels are the next best step. And for highest yield, make sure to choose next generation sequencing panels with genes for distal motor neuropathies, ataxias, and HSP. Okay, so the second case is a 57-year-old man who's coming in with 8 months of progressive pain, numbness, and weakness. He describes this burning pain that started in his feet and ascended over time, followed by paresthesias and then weakness. He is also having lightheadedness with standing, early satiety, dyspnea on exertion, and orthopnea. On exam, he does have orthostatic hypotension. There is some mild pitting edema in his legs, and he does have length-dependent sensory loss, which is more to small fiber temperature and pinprick more than large fiber vibration and proprioception. And his EMG nerve conduction study is consistent with a length-dependent axonal sensory motor polyneuropathy. So he had a next-generation sequencing panel, and it actually came back with a Val30Met mutation in the transthyretin gene. So he was diagnosed with transthyretin-related familial amyloidosis. And after a discussion of potential treatments, he decided to proceed with patisiran. So just a little bit about hereditary transthyretin amyloidosis. This affects 0.3 to 8.7 per million persons per year. The age of onset is between 30 to 90. It can be multisystemic, and so neurologic complications include autonomic neuropathies, sensory motor axonal polyneuropathy, which usually starts with small fibers and over time can progress to pansensory loss. They may also have bilateral carpal tunnel syndrome, vitreous opacities, dementia, seizures, stroke, and hydrocephalus. Cardiac involvement can include restrictive cardiomyopathy, arrhythmias, conduction block, and heart failure, and you may also see nephrotic syndrome. So this was from an expert consensus statement on trying to improve the diagnosis of hereditary transthyretin amyloidosis with neuropathy. And so if you see a patient who's from an endemic area, that is Portugal, Sweden, and parts of Japan, who presents with either a progressive sensory link-dependent polyneuropathy or autonomic dysfunction, plus one of the following: a family history, unexplained weight loss, heart rhythm disorders, vitreous opacities, or renal abnormalities, you should go ahead and test for this. In non-endemic areas, if you see somebody with a rapidly progressive sensory motor axonal polyneuropathy or atypical CIDP, plus one of the following, which also includes family history, bilateral carpal tunnel, autonomic dysfunction, gait disorder, unexplained weight loss, cardiac involvement, vitreous opacities, or kidney changes, go ahead and also consider treating for transthyretin amyloidosis. So the pathophysiology is based on the fact that mutant transthyretin proteins, the tetramers are unstable, and eventually the monomers will form these fibrils, which deposit into the heart, the GI tract, the kidney, and nerve. And so this can cause a rapidly progressive disease with actually onset from symptom onset to death in on average 4.7 years without intervention. This is the genetics of this condition. So over 130 mutations in this gene have been reported, and there is variable penetrance. Some mutations are more associated with the neuropathy and less cardiomyopathy, and some it's the other way around. The Val30Met is actually the most common mutation seen, and it does seem to have more significant neurologic involvement. The reason I'm including this case today is because we do have treatment available for the neuropathy with hereditary transthyretin amyloidosis. And so we have two drugs available now, inotersen and patisiran. The inotersen is an antisense oligonucleotide, and patisiran is a small interfering RNA. Both of them target the mutant TTR mRNA and lead to its degradation to reduce the protein levels. And both are effective. Both slow progression, improve the neuropathy, improve quality of life scores. So the takeaways from this case, if you see somebody with a link-dependent axonal neuropathy with small fiber and autonomic involvement and bilateral carpal tunnel, consider testing for this condition. We do have treatments available that can slow the progression. All right. Case number 3, a 41-year-old man is coming in with a left foot drop. His father and older brother died from ALS. On exam, you see proximal and distal left leg weakness, mild right foot weakness, diffuse hyperreflexia, and diffuse fasciculations. He had an EMG which showed diffuse denervation, and his genetic testing revealed a pathogenic mutation in the SOD1 gene. So he was diagnosed with familial ALS. Just a brief review of ALS. This is a progressive fatal disease that's associated with degeneration of upper and lower motor neurons. The prevalence is about 3 to 5 in 100,000. Sporadic cases do seem to affect men more than women. About 90% of the time, we think this is sporadic, 10% familial, with the familial cases presenting on average about 10 years sooner. And the average life expectancy is about 3 years from the time of diagnosis. So like I mentioned, the presentation is due to degeneration of upper and lower motor neurons. Most commonly, about 2/3 of the time, it presents as limb-onset ALS, where you get weakness and muscle atrophy in an arm or a foot, and over time that spreads to neuroanatomically linked areas. About 1/3 of the time, you can have bulbar onset disease with initially trouble with speech and swallowing. Much more rare is respiratory onset. ALS is also known as Lou Gehrig's disease, the baseball player, and this picture just shows that he likely had one of the common physical exam findings in ALS, the split hand, where there seems to be more involvement in the abductor pollicis brevis and first dorsal interosseous, rather than the abductor digiti minimi, which leads to this split hand. The pathophysiology is really complex. This is another example of genetic heterogeneity. Mutations in multiple different cellular processes have been found to cause ALS, all of which probably lead to this final common pathway of motor neuron degeneration. Most of the cases do end up with these cytoplasmic TDP43 protein inclusions, and with the exception of SOD1, it doesn't do that. So the genetics are complex. As I mentioned before, mutations have been reported in at least 30 genes. Most cases are autosomal dominant, but X-linked and even autosomal recessive cases have been described. So the most common genetic cause are due to the C9orf72 hexanucleotide repeat expansions. The C9orf protein is involved in membrane trafficking and autophagy, but it's likely the pathology results from this toxic repeat RNA, which can be toxic itself and disrupt normal alternative splicing, but actually some of the RNA is even transcribed into this toxic peptide. So in addition to causing ALS, C9orf repeat expansions are also associated with frontotemporal dementia, other types of dementia, and movement disorders. SOD1 is the next most common gene associated with familial ALS, up to 23% of the time. As I mentioned before, there are no TDP43 inclusions. So this protein is actually basically an antioxidant, but it's thought that their mutations cause some sort of toxic gain of function. The pathology is not clearly understood. Others include TDP43. Of note, that knockout mice with TDP43 are embryonic lethal, and even if you knock down TDP43 in mice after they're born, it seems to reduce survival. So that's not going to be a target in the future. Another TDP43 is an RNA processing protein, as is FUS. Another interesting one is ataxin-2, which, as I mentioned before, can cause spinal cerebellar ataxia or ALS. The interesting thing about this is reducing ataxin-2 levels seems to remediate some of the TDP-43 toxicity. So drugs designed to knock down ataxin-2 may be of use in sporadic ALS as well. So on to the diagnosis. At this time, the diagnosis does remain clinical. We have no tests to rule this in, unfortunately. The average time to diagnosis is about 1 year from symptom onset. And the diagnosis remains clinical. Traditionally, we've used this Ellis-Gorrial criteria with definite ALS requiring upper and lower motor neuron signs in 3 body regions. So this is a very specific test, but maybe not as sensitive as we would like, as there's still some diagnostic uncertainty with suspected, possible, probable categories. And just to reduce the emotional stress, and also earlier diagnosis would aid in enrolling patients in clinical trial. There's been a real push to find other criteria which might lead to an earlier diagnosis. So this is something relatively new, the Gold Coast criteria. There was several international groups came together in 2019 to come up with this criteria. And it was validated in a large cross-sectional study too. And so this criteria suggests that if you see someone with progressive motor impairment documented by a history of repeat clinical assessments preceded by normal motor function and upper and lower motor neuron dysfunction in at least one body region, with both in the same, if only one region is involved, or lower motor neuron dysfunction in at least 2 body regions, as well as investigations excluding other disease processes. Another tool I think is helpful. This is available at this website here. This was the ALS Association together with scientists and clinicians and caregivers, and they came up with this tool just to try to help maybe advanced practice providers and trainees, et cetera, to lead to an earlier diagnosis. And I think one of the nice things about this, which you can download from their website, is it has a barcode which you can scan and it'll direct you to the closest ALS multidisciplinary clinic. So for treatment, as of today, we have 2 medications that slow the progression of the disease. Of course, we all know riluzole, which maybe slows things down by 2 or 3 months. It's an oral pill taken twice a day, glutamate antagonist. And then the second medication is Radicava, which was approved in 2017. And this is basically a free radical scavenger. It's an IV infusion, and in a subgroup of earlier onset disease with minimal respiratory symptoms, this medication reduces the rate of decline in the ALS functional rating scale by about 33%. So most of our treatment at this time is just aimed at managing symptoms. Of course, we try to treat mood with SSRIs. We have medication for the pseudobulbar affect, Nudexta, which may also help with bulbar dysfunction. We try to be aggressive with treating fatigue, as this is probably one of the most prevalent symptoms and also one of the least treated. We work in a multidisciplinary care clinic to work on all these symptoms with physical and occupational therapists, respiratory therapists, pulmonology, neuropsychology, et cetera. But the reason I included this case today is because of this study that was published in July of 2020 in the New England Journal of Medicine. And this was a phase 1-2 trial of the antisense oligonucleotide tofersen for SOD1 ALS. So their primary outcome was safety and tolerability, and they used escalating doses of this medication, which is delivered intrathecally. But the encouraging thing was that at the highest dose, there was a significant reduction in the SOD concentration. And there was also a reduced decline in the ALS functional rating scale and the forced vital capacity, and also reduced neurofilament light in the CSF. So again, this was just a phase 1/2 trial, but it was very encouraging, and based on the results of this trial, the drug was made available for compassionate use for patients with SOD1 ALS, for specific patients. So this led to a phase 3 trial, the VALOR trial. The results have been released just at the end of 2021. And unfortunately, the primary endpoint, a change in the ALS-FRS, didn't reach statistical significance at 28 weeks at the highest dose. But it's still intriguing. The secondary endpoints, there was a significant reduction in the CSF SOD1 concentration, similar to the prior study. And also, again, they found reduced concentrations of neurofilament light in the CSF. So some questions came up. Was the intervention soon enough? Was this trial long enough? And I do want to point out that there is a current ongoing trial that's recruiting individuals with mutations in SOD1 who are asymptomatic. And the other encouraging thing is that there's many drugs that are currently being evaluated for other familial ALS. You can see here FUS, C9orf, and the ataxin-2 are currently being evaluated. So the takeaways from this case, I would consider genetic testing in all ALS patients, and hopefully we will have more treatment options available in the future. Okay, so the next case is a 45-year-old man who presents with progressive weakness, which began in his hands, followed by changes in speech, and most recently, frequent falls due to tripping. He has a family history of 2 sisters with similar symptoms, and one of their children had severe hypotonia at birth. On exam, he has frontal balding, facial weakness, distal extremity weakness, and atrophy and myotonia. So his EMG did show myotonia and myopathic units. And because of this, we performed a repeat expansion analysis in the DMPK gene, which came back with expanded repeats. And so this patient was diagnosed with myotonic dystrophy type 1. So DM1, the pathophysiology, is related to this repeat expanded RNA, which accumulates in the nucleus and binds and disrupts proteins that are needed for normal alternative splicing. And it affects multiple genes, hence the multisystemic nature of this disease. Just for example, the chloride channel in normal adults excludes exon 7A, but in DM1, 7A is included. And 7A actually has a stop codon, so you get less chloride channels with impaired muscle repolarization and hence myotonia. Another example is that there's missplicing in the insulin receptor gene, which has been associated with diabetes. Another thing to keep in mind about DM1 is this is a disease where the repeat expansion may expand from one generation to the next, especially with maternal transmission. This is anticipation. And one more thing, so again, myotonic dystrophy type 1 is the most common inherited muscle disease in adults. So this is the pattern of skeletal muscle weakness and wasting that we see. It affects the distal extremities. So in the hands, especially finger flexors and wrist flexors are affected, and that impairs handwriting and dexterity and limits their ability to carry out their own activities of daily living. In the lower extremity, we see foot drop, so they might trip or have difficulty with ambulating. They also have a lot of facial muscle weakness, which can reduce facial expressions. Sometimes they have ptosis, temporal atrophy. They can have weakness in the tongue and palate, which can lead to this indistinct speech and also difficulty with chewing and swallowing. And sometimes there can be weakness in neck flexors and extensors, and so they might have a head drop. But again, this is a multisystemic disease with symptoms from head to toe. So these patients, if you were to image their central nervous system, sometimes there is atrophy, ventricular dilation. They can have some white matter changes. It's unclear if these changes correlate with any kind of behavioral or cognitive changes. Up to 60% of patients will have early onset cataracts, and with lamp examination, you may see these multicolor glistening opacities, hence the name Christmas tree cataracts. Actually, the most common cause of death in this group is respiratory failure, which can be due to respiratory muscle weakness, aspiration, obstructive sleep apnea, or even reduced central drive. Another common cause of death is cardiac conduction defects due to myocardial fibrosis. They get arrhythmias and rarely a cardiomyopathy as well. There can be many different endocrine changes, sometimes diabetes, hypothyroidism, hypoparathyroidism, adrenal insufficiency, androgen insufficiency. Up to 80% of patients get GI symptoms, and actually these can be some of the most prominent symptoms they have. They may have abdominal pain, bloating, diarrhea, constipation, even megacolon and perforation. And there is a 2 times risk of cancer in this group. They also can get these pilomatrixomas. These are these little firm nodules in the head and scalp. These are benign tumors of the hair matrix. And recurrent pilomatrixomas have even led to the diagnosis of DM1. So to make the diagnosis, serum CK may be normal or increased. On EMG, you will see myotonia and myopathic units. Although we don't routinely do this, muscle biopsy may show increased internalized nuclei. And again, genetic testing can be done to make the diagnosis. I do want to mention again that the trinucleotide repeats are not well picked up by Sanger sequencing or next generation sequencing. So there are specific techniques used to confirm the repeat expanded. So I find this document that was published in 2018 and is available on this website, myotonic.org. It's a 56-page consensus statement made by experts in the field who have a lot of experience managing these patients. And it just walks you through all aspects of caring for these individuals. And I won't go through all of it, but just some of the highlights I've summarized here. So these patients should avoid succinylcholine. It can cause this masseter spasm, increased potassium, and sometimes it's variably effective. And you do need to closely monitor their respiratory and cardiac function after and during surgery. They should have their pulmonary function test monitored every 6 months. They should have their cardiovascular function monitored with an EKG every year and a Holter monitor every 3 to 5 years. And there may be a role for prophylactic ICD and pacemaker replacement in this group due to the risk of sudden death from the arrhythmias. The recommendation is to check GGT and bilirubin yearly and to encourage a high fiber diet with increased water as well. For women with DM1 who become pregnant, they should be referred to a high-risk obstetrician. They should have access to genetic counseling, and they should give birth in a location that does have a neonatal ICU available. For the weakness and myotonia, we do encourage exercise as well as physical occupational therapy, orthotics, and assistive devices as needed. For the myotonia, you could consider using mexiletine, which is a class 1B antiarrhythmic. It's a sodium channel blocker. The caution here is that it could potentially worsen cardiac conduction abnormalities. And so if you were to prescribe this, I would recommend serial EKGs to monitor for that as well. These patients need yearly eye exams, and they should also have their endocrine function monitored routinely, TSH, and lipids every 3 years, and either a hemoglobin A1C or fasting glucose yearly. So the takeaways from this case, DM1 has a distinct phenotype. Repeat expansion testing may not be included in widely available next-generation sequencing panels, and treatment at this time remains supportive. So just monitor and address all potential symptoms. I should mention there is a phase 1-2 trial underway right now of a small interfering RNA molecule to try to lower the toxic repeat RNA levels. So stay tuned. Hopefully we'll have some treatment available here as well in the future. Okay, this is my final case. A 40-year-old man is presenting with 1 year of progressive proximal muscle weakness, orthopnea, and dyspnea on exertion. He did meet all milestones on time, and he was athletic as a child. His past medical history and family history are negative, and on exam, you see axial and proximal muscle weakness, scapular winging, and no clinical myotonia. His CK is mildly elevated to the 600s, and on EMG, there are myopathic units proximally, as well as myotonia in paraspinal and proximal lower extremity muscles. So just because of this kind of subacute onset, we checked a muscle biopsy, which showed increased myofiber glycogen. Based on this and the fact that he had a limb girdle pattern of weakness with some respiratory involvement by history, we did go ahead and do dried blood spot, which did show reduced alpha acid glucosidase enzymatic activity. And so we went ahead and sequenced this gene, and this showed a compound heterozygous mutation in the GAA gene. And so this patient was diagnosed with Pompe disease. So Pompe disease affects about 1 in 40,000. It's autosomal recessive. The late onset form presents with limb girdle weakness, which usually involves pelvic muscles more than shoulder muscles, as well as prominent axial weakness, scapular winging, significant orthopnea, and dyspnea on exertion. The CK can be normal or elevated, and on EMG, you'll see myopathic units as well as sometimes myotonia in the thoracic paraspinal muscles. The pathophysiology here is due to reduced acid alpha glucosidase enzymatic activity. So what happens is glycogen accumulates in the lysosome, and eventually the lysosome bursts, releasing glycogen and other toxic components into the cytoplasm. Also, it seems that there's disrupted autophagy, so impaired clearance of misfolded proteins and non-functioning organelles as well. And also there's some changes in the ability of satellite cells to regenerate muscles in this disease. The spectrum of disease results from the changes in the residual enzymatic activity. So in infantile onset Pompe disease, where the symptom onset is before 12 months of age, there is less residual enzymatic activity, and these babies present with just severe generalized weakness, respiratory failure, and a severe progressive cardiomyopathy. In adults who have a little bit more functioning enzymatic activity, the presentation can be more mild, and with or without the cardiac involvement. So the diagnosis can be suggested by muscle biopsy, which may show vacuoles, glycogen staining with the PAS stain, and in later stages you might also see the fibrous fatty replacement. Genetic testing can be helpful, although there have been over 500 mutations reported. About half of these are missense, but insertions, deletions, and even a splice site change, which is actually a very common cause of late onset Pompe disease and concations, have been reported. And just, again, remember that these might not be picked up on whole exome or next generation sequencing panels. The other test you can do is just to look at the acid alpha glucosidase enzymatic activity itself. You can do this on muscle biopsy or on a skin biopsy for cultured skin fibroblasts, or even probably the easiest is the dried blood spot. The thing to know about this is that there is a pseudodeficiency, so there's a benign variant in this gene which causes there to be reduced enzymatic activity when you do this assay. Although these individuals do not have Pompe disease, they're normal, and there are certain populations, like in Asians, it's been estimated that up to 4% may have this change. So you may need to do both testing for confirmation. And the reason I've included Pompe's disease is because we have treatment available now. Actually, Lumazyme, or L-glucosidase alpha, was approved in 2006, and just last year we had the approval of Aval-glucosidase alpha, or Nexviazyme. So the consensus statement is to start enzyme replacement therapy as soon as the diagnosis is made in symptomatic individuals. However, over time, we've noticed that patients will initially improve, but after about 3 to 5 years, they might also begin to experience a decline. The Aval-glucosidase alpha is a recombinant enzyme that has these extra mannose-6-phosphate residues, and that is supposed to target it more into the muscle itself. And the study, this COMET study, which I've shown 2 of the figures from this below, it didn't reach superiority, but there was a trend towards improvement in the FVC and the 6-minute walk test with Nexviazyme. The exciting thing is that there are actually other medications in the works as well. There is another modified enzyme together with a stabilizer being reviewed by the FDA right now, and it's possible that we may also have gene replacement for this condition in the future too. So the takeaways for this case, I would recommend considering Pompe disease in patients with progressive proximal, axial, and respiratory weakness. Just be aware there's no perfect test, and to consider both genetic testing and enzymatic activity testing. And again, treatment options are expanding. So to summarize here, the genetic heterogeneity, phenotypic pleiotropy often make single gene testing inefficient. Next generation sequencing is faster, sometimes free, and is a more efficient way to confirm genetic diagnosis. But just again, remember some of the most common diseases aren't included in these panels. And we have treatments available to improve outcomes for several of these genetic neuromuscular diseases, with hopefully more in the pipeline and available soon. So, thank you.
Wow. Dr. Sharp, you are impeccable in your time management. And watching your presentation humbles me. We need more colleagues like you to help us to navigate these neuromuscular disorders. Really, really awesome. Thank you. We have questions from the audience. If I may remind the group, please ask your questions while we still have some time to have the questions presented to the speaker. I think the previous presenter had 2 questions that came just before the time was due. The question for you, Dr. Sharp, is a question that we all have when we see these cases. What is the secret? What is that lab that you use for your next generation sequencing panels? Because, I mean, they are so costly.
So I have been using Invitae a lot recently. They do have the ALS identified panel, which includes the C9orf hexanucleotide repeat, and they also have sponsored testing for Duchenne muscular dystrophy and the hereditary transthyretin amyloidosis.
Because you told us that there were more than 600 genes known to cause neuromuscular disease or disorders, and if each one of those tests costed $5, which they don't, that in itself would be $3,000 right there. So we have another question for you from the audience, and the question is, if you would please expand on the NGSs and the whole exome testing.
You mean the difference between the two, or I guess. All right. Well, so the next generation sequencing panels test multiple genes, this whole panel of genes all at once. The whole exome sequencing can look at certain areas of the exome in more detail, but it's really checking all of the expressed exons. So I don't know if that clears things up or makes things more murky.
I cannot say that I understand the question myself, but literally the way the question was asked to us, can you expand on NGSs and the whole exome testing? So I'm sorry. Thank you. Any more questions?
Dr. Sharp, that was a beautiful talk. Thank you so much. For the pediatric neurologists in the audience, we often end up doing whole exome sequencing for our pediatric patients, maybe for an unrelated reason. And in the event that we find mutations in one of these genes that might not have onset until adulthood, when do you recommend starting screening? Are there treatments we should be recommending for asymptomatic patients? Could you talk about that?
Yes, this will probably vary depending on what you find and whether or not there's a treatment available. So, for example, for Pompe's disease, you would probably monitor these people very closely to see if they start to develop weakness so that you could initiate the enzyme replacement therapy. But I think having them hooked up with a neuromuscular specialist to do that and see them back every so often would be a great idea.
Any more questions for Dr. Sharp? Again, thank you so much. It was very, very informative.